is okay?
Yes, everything's fine.
Great. Lovely to meet everyone. I'm Nicu. I mean, the bio is pretty much mentioned, but I was asked today to talk to you about how do we assess the unwell patient. And I've just scribbled, as I said, quite a friendly guide. Just a few disclaimers. I don't, I'm not claiming I'm a pro and I'm an expert. I don't think you can ever be the ultimate expert in medicine. Every patient is different. However, what we try to achieve today is have a bit of a framework about how we should assess an unwell patient and why this is better done in a structurized framework is essentially just going to be better for everyone, much more smoother and leading essentially to better outcomes for the patient. And you can get the laurels as well of being a very good doctor. So, sure, let's see if it works. Yep. So we're not really going to sing the ABCD song, but essentially this is what the day is going to be about. It's going to be learning the ABCDEs that we've been familiar with since childhood. But in essence, ABCDEs, I'm sure most of you as medical graduates, I understand a few of you maybe already being involved in work in the NHS, but even anywhere else, even where I trained in Moldova, where I thought, it's far from being a third world country. We've learned about ABCDs in school as well. So A stands for airway, B for breathing, C for circulation, D for disability, which always put me off a little bit. I couldn't really understand it when I first started training in the UK, and E for exposure. So this framework has been kind of like gradually built since the 50s. First, it was Dr. Safar, who's an intensivist who developed essentially the A and Bs. He took volunteers actually and put them, gave them muscle relaxants and put them essentially in respiratory failure. And then delivered them oxygen through a mask, and he proved that he can keep them alive, and actually they can wake up and be fine. Then came Dr. Kuvenhoven, who is a physicist in essence, but he really liked electricity and studying it. So he thought of ways of how he can use electricity in in helping a patient in cardiac arrest. And one of his residents was the first person to ever deliver defibrillation to a patient in VF, and that was in 1957, so quite a long time ago. Then Dr. James Steiner, he was an orthopedic surgeon. He got into a plane crash with his family. So even back then, orthopods were very rich. It was a private plane crash. He went to a hospital with his family, and he realized how disorganized things are. And then he came with what essentially was the basis of the ATLS protocol, which included the comprehensive ABCD assessment. So nowadays, ABCDE is pretty much in everyone's mouths and minds when they come across an unwell patient, wherever you are. You can be in a GP practice, seeing someone who appears to you very unwell. You can be in the emergency department. You can be on a ward. But you'd be doing the same thing when you come across an unwell patient. The principles of ABCDE is to, in essence, treat life-threatening issues as you discover them, moving through the different parts of the A, the B, the C, D, and E. Another principle is to always assess what you do. It may not be immediate, but you might need to progress to your next step and then come back and reassess. Did what I did previously, did that work? Hasn't made any improvements. But we'll always have to have at least a one complete A2E assessment. Very important here is to make sure that you've got help. Luckily, I guess, I'm not sure about other countries because I only practiced medicine, so to say, in the NHS, but you're never alone when you're dealing with an unwell patient. So make sure you know who's around you, ask for help if you don't have people around you, and try to get everyone something to do so that everyone feels involved and they can contribute. It was already mentioned about the SpR. This is how we communicate effectively with our colleagues. And then again, it was mentioned in previous lecture about treatment limitations and escalation of care. I guess at your stage, it might be a bit daunting to discuss with someone about limitations of care, but you will be in that position, and you'll find that most of the time, patients and relatives are quite open to this discussion and very understanding as well. And right, so this is basically what you might be experiencing next time you're on duty in the NHS. So you'll be called, you'll be bleeped, you'll be asked, you'll be grabbed from the wherever you were doing. And it's like, doctor, can you please come and assess this patient? You can be part of a few members team. You can be by yourself. But make sure that you first get a really brief handover from the person who asked you for help. Okay, what's the problem? Who's this patient? We seem to be fixated on age anyway, a lot of the times, and it just gets on with their name and age. It's always at the beginning of any handover. Why the patient is in the hospital, and why do I really need to review this patient right now? What's the concern? Make sure that obviously you make yourself known, who you are, and you're gonna listen, because the following information can be really helpful, will be very helpful actually. So after you've taken the handover from the person who's asked you to review someone unwell, make sure that you ask them for a favor in return. Okay, well, can you please grab me the notes of the patient? Or very commonly, and I guess most of the hospitals in the NHS have a computer on wheels. Or can you grab a computer on wheels for me? Or can you bring in the drop chart? Can be, some places it can be on the intranet, or it can be on paper. And depending on the level of the concern of the person who's asking you to review someone, ask, do you think the crush trolley is needed, which is this thing pictured here, which essentially will have all your ABCDEs tools and the things to monitor and treat an unwell patient with. Then obviously you're going to approach your patient. Naturally, people just have a quick glance from the end of the bed, like here or here in this picture, and you just ask them, okay, how are you? What's happening? How are you feeling? Obviously, if the patient is alert, they will talk to you, hopefully. And so that's one of the first, well, maybe not the first after your visual inspection, quick bedside, but it'll be the next thing that you'll hear from them. Can they actually talk? Now, if they can talk and you hear a very nice, smooth, vocal expression, then it means that one, they're alert, and two, their airway is patent. So we mentioned A as the airway. That's the first bit we're going to assess in any unwell patient. And the goal of this assessment is to make sure that their airway is patent, so that oxygen can get in, CO2 can get out. That's the main idea of this assessment. Now, how are we going to assess the airway? First, we're going to, obviously, we've eyeballed the patient, and then we're going to listen when they talk to us or just when they breathe. Is there any stridor? Is there any gurgling or any snoring? So snoring would imply that the patient is unresponsive, asleep, obtunded, drowsy. Many ways to describe that. Gurgling means there's something in the airways, and that's probably not helping them get enough oxygen. Stridor, again, means something is in the upper airways, likely constricting the airway or blocking the airway. So that needs to be dealt with. We're going to look at the patient as we listen, see for any facial swelling, lip, tongue, neck swelling. Are they blue? Are they cyanosed? Do they use accessory muscles when they breathe? Is their abdomen and chest moving in a seesaw breathing pattern? Can we see any secretions coming out of the mouth or any foreign body sticking out, like dentures very often? So things that we can do as the person assessing as the doctor assessing the unwell patient is we can ask for the suction if we think there's secretions to be suctions, like vomiting or blood. This is commonly what we find in the NHS hospitals. And you can suction like in this manner with just what you can essentially go around the mouth and inside the mouth. Don't try to shove it all the way back into the throat. If that doesn't really clear the airway, you don't get really a nice smooth breathing in and out, then probably the airway is obstructed. So you need to do some extra maneuvers like a jaw thrust here in this picture, or a head tilt and the chin lift. So most of the times we sit by the patient's right-hand side, but your left hand goes on their forehead, tilts it back, and then you lift the chin with the other hand. So that will secure an airway. And again, if that is not enough, and you still hear abnormal sounds, or the patient doesn't look to be breathing normally at that stage, or they're unresponsive, you consider adjuncts like a nasopharyngeal airway here in this picture, or an oropharyngeal airway. There are more advanced airways. You might not be necessarily asked to be the one to do that. So things like laryngeal masks or eye gels. Again, you will have help to secure those in place if needed to. But these are the basic things that you can do, and it literally takes you probably 15, 20 seconds to just quickly eyeball, listen, see whether you can suction anything. Okay, that doesn't work. Let's put an adjunct in as well. So that's your airway is now secure. You're breathing more relaxed, but not really, because you have to assess the next part, which is your breathing. Now, I'm a strong believer in visual slides. So there's a lot of stuff on the slide. Please don't get, I know you might feel a bit dizzy when you go from one picture to the other trying to go through. Let's just listen and just go through with my pointer. So B for breathing, the goal of this assessment is to make sure that we deliver to the patient enough oxygen, and then we can ventilate their lungs effectively, i.e. clearing the CO2 and getting the oxygen in as well. So again, from things that we can look and listen to when we have the patient in front of us, again, are they blue, their lips blue? Are they tripoding? And is that they're sitting up, they're trying to get as much oxygen as they can in the lungs? Do they use accessory muscles? Similarly, the abdomen, the intercostal muscles. Is there an abnormal breathing pattern like Kussmaul we see in DKA with severe acidosis, or Cheyne-Stokes when they're unresponsive, comatose? Do you see any chest drains inserted? That may be the case as well. Very next thing you're going to go on and do is feel for their trachea. It's frequently taught that it's quite an uncomfortable thing to do if done properly. It can feel a bit choking to the alert patient, but do feel with your finger, with your middle finger, where the trachea is, and assess if there's enough space on the sides. So that means, okay, the trachea is in the middle, or the trachea is shifted to one side. Now, then you're going to add up that to your next assessment, like the listening. So you're going to listen both lungs for what are the oscillatory sounds? Are they reduced? Are they quiet? Is there wheeze? Are there crackles? Is there no sound at all? And then you put that together with your tracheal position, so you can make up something in your mind. Okay, well, the trachea seems to be deviated to one side. However, the other side is completely silent. Okay, is that a pneumothorax, a tension pneumothorax, which is pushing the lungs away? Or again, you listen, you can't really hear much air entry, but the trachea is deviated to the same side. So is there a lobar collapse, which is causing my patient to be unwell? Then you're going to go through your monitoring of the things that you can actually check. So probably by the time you've seen the patient, somebody already has assessed their respiratory rate, and that can be very low, it can be very high. You would have had a reading for the oxygen saturation. And at that stage, you need to think, well, if my patient is breathless, especially if their respiratory rate is low, high, saturation is low, you would want to get an arterial blood gas. And now this is just an example of what a typical ABG result looks like in the NHS. I think most of the machines have this kind of pattern, so visually it will look like this, but there are very important things to get here, like your pH, your CO2 concentration, your oxygen concentration, the metabolic response to this insult, the lactate, glucose. There's so many things, but if we're talking about breathing, that you'll find most of your answers here already. But there's also like methemoglobin and carboxyhemoglobin as well. So other important things in the gas. Anyway, so what can you do now, doctor? If your patient is feeling breathless, their saturation is low, and they just don't look right. So you can usually we make sure that the patient is set up right. That gives their lungs and better expansion. You give the oxygen if the oxygen is low on saturation. Again, most of the guidelines and protocols would advise you to give oxygen to the patient who's unwell, even if their saturation is normal. If the patient appears breathless or complains to be breathless. So you would apply the oxygen and you titrate that to their saturation readings at the fingertips. Most of the patients, you would want saturation levels of 94 to 98, but you have to be careful with patients who have not necessarily COPD, but other conditions as well that put them at risk of hypercapnic failure, where you essentially target for low saturations. If you found that the problem is here, it's in, so the A is secure, but the B is the problem, the patient is wheezy, the patient has COPD, their saturations are low, the ABG shows hypercapnia as well, the CO2 is high, they might have low oxygen as well with that, then you can consider things like NIV. But again, I think at your training stage, where you are in a medical career, you might not necessarily be the person who's like, okay, we need to do this right now. You will have seniors to help you with this decision. And again, what things can you do to help your patient? So based on the story, the brief handover you had from your nursing staff or concerned colleagues, and with your assessment of the A and B, you might consider nebulizers if they're wheezy, if they have history of asthma and COPD, antibiotics, steroids. Again, this is things that all helps with bronchodilation, treating a chest infection and pneumonia. Think about low molecular weight heparin if the concern could be pulmonary embolism, or how to actually deal with this pneumothorax if there is one. And remember that tension pneumothorax should always be a clinical diagnosis. However, very frequently in practice, it might be tricky unless the patient is really crashing. After you've done this, make sure that you've reassessed, just like we did in A. Okay, we've secured the airway and we're happy with that. Let's move on. Similarly, you might not get an immediate response in the sense that your patient is going to be flipped a switch and they're magically a lot better now. They might do, but very rarely, but there will be some signs of improving. Like the saturation is low, you've applied some oxygen, a minute or two down the line, the oxygen reading at the fingertip is improving, it's increasing, or they appear less breathless. So make sure you do reassess your patient with every intervention you have at this stage. Just some pictures here about what a patient with pneumonia might look like. Sorry, chest x-ray of a pneumonia. And where do we do emergency chest drains for pneumothorax? So if it's a tension pneumothorax, we do need to do it right here, right now. And then it's the second intercostal space, right in the midclavicular line. Chest tubes go in the safety triangle. Right, so happy with B's. We've done some stuff. It looks like things are a bit more stable. We reassessed. Okay, let's move on to C. So C stands for circulation, and the goal of this is to achieve what you frequently come across the terminology. My patient is hemodynamically stable, which means their blood pressure is not in the boots, is not crashing, and their heart rate again is not through the roof or again through the boots, very, very low or very, very high. So that's what hemodynamic stability stands for. Visual clues when we see our patient, again, you might notice the same cyanosis, or a patient might appear to be pale. They may seem swollen. They can have orbital swelling, facial swelling, not necessarily like angioedema swelling, but they just look puffy. And you might see that throughout the body as well. Definitely look at the neck veins. They may give you some clues about their intravascular status, as well as other conditions that can affect your circulation, like a cardiac tamponade. Similarly, have a look around for any drains because they may be oozing blood from the drain or inside the drain or outside the drain. Any signs of hemorrhage. You're going to touch your patient to make sure that peripherally are they cold, are they warm, are they hot for the same instance? What do the pulses feel like peripherally? Are they even palpable? And what's the capillary refill time? That gives you a bit of a clue about how well their pumping function of the heart is. How well can they generate an effective blood flow to the peripheries? You're going to listen to the patient's heart as well. See if you do listen to heart sounds, do they appear to be muffled completely, and the patient has a distended neck, and their blood pressure is very low to suggest a cardiac tamponade. Third heart sound, commonly associated with heart failure, or a new murmur, which it might be new to you or new to the paperwork. It might not necessarily be new to the patient or predate a definitive diagnosis of infective endocarditis. But again, frequently, if you come across a patient with a new murmur, you can have infective endocarditis in your bag of differential diagnosis, as well as acute MR, rupture of papillary muscles. So you've assessed, and then what can you do, doctor, to help my patient? Well, first of all, you've again asked the observations, or you have them at the bedside already with a monitor. You can see the patient's heart rate and their blood pressure. And if they have extra charts, if they've been in hospital already, then they may have a fluid balance chart as well, which tells you how much fluid has gone into this patient today, both orally and intravenously, or NG or NJ, whatever means, and how much has come out. After you assess that, make sure that part of the C as well is to, if your patient doesn't have a cannula, doesn't have intravenous access, then you do that. While you do that, you do take some blood tests as well. Based on the history, if it sounds a lot like an infection, sepsis, bleeding, you would need blood cultures and cross-matching. ECG goes in here as well, and urinary catheter, so that we can make sure that we know what's coming out of the patient, what the urinary output is. And again, what things you can do by the bedside, you can, if the patient is hypotensive, hypovolemic, based on our assessment, then we give it fluid bolus. Commonly in the hospital, you'll have either a choice of normal saline or Hartmann's. You are absolutely fine to give either of them. The usual volumes we talk about is 0.5 liter or 500 mils, and that goes stat. When we say stat, that means you've attached it to the cannula, you've opened up the infusion set, and just let it run freely. Depends on the cannula size. That can be drip, 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 or like a laminar flow. You can try and attach this thing in here, especially if your patient has a very low blood pressure and you need to give them fluids fast or blood fast. You put it in a pressure bag. Your nursing staff will be very helpful, but if you just try and learn how to do it once, you don't need to learn it again. It's very easy and straightforward. If your patient is, you think, at risk of overload, so very commonly the nurses will say, "Oh, but doctor, his legs are so edematous," or her legs, I think they may have heart failure. However, the blood pressure is still 80/40, and your patient appears unwell. No one's going to judge you if you are giving just a smaller volume of fluid and see what is their cardiovascular system's response going to be to that 250 mils of normal saline or Hartmann's. And if you're assessing that there's hemorrhage going on, there's blood oozing from the drains or catheter or somewhere else, just, hemorrhage, then you might need to give blood transfusion or consider it here as well, or ask for it. And then similarly, we reassess. Has our fluid bolus or fluid challenge, what we, again, it's a common terminology used here, has that helped? Is the blood pressure improving now? You want to recycle, you want to remeasure it every 5 minutes, 10, 15. Has my, whatever I did that make a difference? What did that ECG look like? You think about the tachycardia and the bradycardia algorithms here as well. Other things I've included here in the slide are things like if this so far looks and feels like an acute coronary syndrome, think about giving antiplatelets, morphine, GTN, oxygen. If it looks like sepsis, make sure you follow a sepsis 6 pathway. If the patient appears to be overloaded, think about stopping those fluids and giving some diuretics, GTN, oxygen, non-invasive ventilation. Vasopressors, again, this comes on at a more senior stage, and you usually have to have a few people involved in this decision. Thrombolysis, if it's a massive pulmonary embolism leading to hemodynamic instability, or pericardiocentesis. If clinically, maybe you do a bedside ultrasound as well, or your colleague does, and you find a large tamponade and the right ventricle just seems to be bulging at the left ventricle, then you have to consider pericardiocentesis. So, as I said, quite a lot to go through, but hopefully so far you would have done with, to be honest with you, most of the time people tend to stop at ABC and then kind of like ignore the rest, unless clinically the patient is just unconscious, which prompts you to go make sure that you do the rest as well. But make sure you cover your ABCs and reassess your every intervention. So moving on to D, or disability, the goal of this is we want to assess what's this patient's neurological state. Very commonly, you've already encountered your patient, you've done some things with them, so you know whether they are alert, are they confused, disorientated, are they agitated? Do they respond just when you talk to them? Otherwise, they just seem to be sleeping and drowsy. Do they only respond when you inflict some pain? Or are they completely unresponsive to any stimuli at all? So you can squeeze the trapezium, they're still unresponsive. Shouting, they don't seem to respond to that either. Things that you may notice straight away when you look at the patient is abnormal posture. It is common, especially if you work in emergency department or you're part of the medical emergency team and you go and see patients in new admissions. You might see some of them, what we call posturing. They have an abnormal posture like decorticate, where they have a flexor response, or decerebrate, when they have an extensor response. It's not like one is better than the other. Usually this is quite bad. Decerebrate means really bad. There's some problem at the midbrain or the pons. But this is the kind of thing that you might notice straight away. You may be given a handover about this patient having had some seizures, or you witness seizure, and you will check patients' pupils and their reaction to light. When you feel your patient, you're gonna gently roll their arm or lift their arm, ask them to keep it up if they're awake, but you want to see what the tone of the arm is. That predates you some more information about whether they could have a upper motor or a lower motor lesion, and how do they feel peripherally? Do they actually have a fever, or is the temperature very, very low? And then things that you ask your nursing staff, or you would do at that stage, you would check the patient's blood glucose / ketones, commonly checked together, especially if there's a history of diabetes or your initial glucose reading was quite high, usually above 11, prompted to maybe consider doing a ketone check as well. And you would ask your nursing staff, can I see the drug chart as well for any medication that might make your patient to be unresponsive, sedated, drowsy, obtunded. So things like opioids and sedatives, even anxiolytics and antipsychotics as well. If you identify that there's a problem with the blood glucose, when it's less than 5, it's hypoglycemic, you consider correcting that based on how low it is. Very commonly, it's intravenous glucose. And then you may consider a CT head as well if you've not really found any problems. However, maybe your patient has an abnormal posture, maybe they have seizures, the pupils don't look quite right, the limb tone doesn't look quite right, or the power on assessing the patient. At this stage, again, you would think about, what can I do? So you may have corrected the hypoglycemia if that was the problem, or you've actually started intravenous insulin if the patient is hyperglycemia or DKA, Or you think about antidotes. Well, the history is suggestive that the patient has been given or have been taken some opioids or benzos, and now they are, unresponsive or very minimal response. So think about antidotes, commonly is naloxone for opioids, flumazenil for benzos. Think about giving fluids, benzos if they have seizures, and think about, again, reassessing that airway. If your patient has seizures, you're not sure, are they actually maintaining their airway? Reassess what you've done at this stage before you move on to E. Again, frequently kind of like overlooked, but equally important. You can get lots of clues from just having a very good look all around your patient. So the goal of this assessment is to reveal other signs, visual signs that you may not picked up during your first assessment, A, B, C, and D. The underlying principle is to maintain dignity, so you don't literally make your patient bare naked, just so you can have a very good look around, make sure you expose the part that you examine while keeping the others covered. And that's also going to help you preserve patient heat. So things you're going to look for, typically, commonly it's rashes, concerning rashes, like a non-blanching rash on the limbs or maybe the torso as well. Urticaria that you see with, you may see with angioedema or severe allergic reactions. Bruises, again, predating maybe some problem with the clotting for this patient. Cellulitis, predating a site of infection. Are the drains working or are they bleeding? Is there any hemorrhage? That could be just fresh blood you see, or blood with clots, or altered blood like we see with patients having melena. Catheter, do they have one? What does the urine look like? Is it dark and concentrated? Or vice versa, or is there blood in it? And look at the patient's back as well. You might frequently find, unfortunately, especially with elderly people who are bedbound, you find pressure sores which become really infected and very deep and ulcerating and whatnot. At this stage, again, you, as part of your assessment, you'll feel the patient's abdomen, and you may look at the legs for edema or check the calves if they may have a DVT. Make sure the temperature is checked. This is one of the things you'll ask your nursing staff. And if they have a fluid balance chart, you'll look at that as well. If they're hypothermic, you will think about, how do I warm up my patient? Based on how low the temperature is, you can go from just a few blankets maybe to, what was this thing in picture here, a bear hugger. It's not a bear hugger, by the way. It's frequently misspelled. It's not cuddling a bear as such. It's just the brand, a German brand, Bayer. Or you think about warm compresses on extremities. If your patient is actually very hot, you think about antipyretics like paracetamol, a fan, some ice packs in the groins and axilla. This right here is a fluids warmer. So similarly, if your patient is very hypothermic and they need fluids, let's say, as well, then you can actually warm them up. Okay, so we've gone through A, B, C, D, E. We've pretty much reassessed at every stage what we've done. We have a bit of an understanding after a handover from the nursing staff, the observations we've had throughout our examination. By this stage, you should have a bit of an understanding of what is wrong, and it can be a quite broad differential diagnosis. It can be narrow. Every clinician is different. You may be Dr. House and just, going right to the diagnosis from your first eyeballing the patient, but that doesn't necessarily mean it's that. So, but make sure you have one initial complete assessment, A to E. And this is what, we don't have these on the walls, or we don't carry things like that, but it's a very helpful visual chart, a full A, B, C, D, E, things that you're expected to look for when you examine the A, the B, the C, the E. What is the intervention that we can do then and there, and what is the goal? Right, so I'm not going to hang on too much onto this slide. This is pretty much what we've gone through so far. You will have the presentation at the end anyway, so feel free to use that printout, make yourself a memory, a flashcard, like a card, whatever. Now, after we've done, as I said, we've reviewed everything, we have a bit of an understanding of what's going on. If you by that stage, you don't have a senior around you and you think that the senior help is needed, whether you're not sure if your interventions have been efficient, you're not sure if you have the right diagnosis for the patient, or you don't know what's going on, you want your senior to give you some advice, please do seek it at that time and use the SpR. What I found very useful, so SpR is amazing. I don't think you need to use anything else, but what I've found myself doing is actually doing our SpR. So I would, if I'm the junior and I want my senior to give me some advice or see the patient for me, I would start with, I'm Nicu, I'm on this ward, I am concerned about this patient, and I would actually like you to come and see the patient, or I actually am not concerned, but I do have some questions, because it just sets the tone of the discussion, and whoever you're talking to on the other end, it sets their tone of listening and engagement as well. If you start with, you need to come and see this patient, I'm very worried about them, you're probably just gonna hear the dial beep because they'll be on their way. Or if you start with, I'm not concerned, but I do need some advice, this is what's happened, then again, it sets us, a much more relaxed tone. After your review, again, if you feel like you as the doctor being there with the unwell patient, you need someone's help apart from your senior, or your senior has asked you to get someone else's help. So if it comes to a problem with or airway, then your next port of call would be your senior doctor, your medical registrar, your anesthetics department or ENT. For B, breathing, again, commonly medical registrar on duty, intensive care unit, respiratory doctors or NIV specialty nurses. C, similarly, you'll find medical registrar being asked for pretty much everywhere. But ITU, cardiology, surgery, if they have a hemorrhage post-op, or they have an acute abdomen, they're bleeding inside. D, again, ITU, neurology, neurosurgery, and E, whatever's relevant to the problem you identified. But bear in mind that, again, this is the stage where you need to consider getting your senior help or getting someone else involved in this case. After you've done all of that and you've saved your patient, you've stabilized your patient, do make sure that that goes into the patient's notes. This is usually done two ways. If your patient was so unwell that it led to what we call a medical emergency call, this is where a bleep goes off and a lot of people rush in to see the said patient, then most of the hospitals have a set medical emergency form, which will be filled by one of the doctors. But if that's not the case, you would just ask to see someone who's unwell. You've done your A to E, you're happy now, you've got time to document. Try to do that as soon as possible. Make sure that you have at least 3 key identifiables for the patient. Usually that's their name and date of birth and their hospital number. So those 3 would be unique to them, or a combination of them will be unique to them. Start with the date and the time of your entry here, who you are, what's your grade. And obviously, as this has happened, let's say 15 minutes ago, 20 minutes ago, just start with written in retrospect. Most of you being asked to see the patient who's unwell starts with ATSB, or asked to see patient, followed by the reason you were asked to see, whether their observations are abnormal, or the patient is unresponsive, the patient looks breathless, whatever the reason for their review was. You can use your ABCD in here as well to actually document. It does make it look very professional, very neat, and make sure that it's kind of like it's a visual reminder for you as well, right? Okay, I'm going to document an ABCD pattern as I've examined, or have I forgotten something somewhere, or actually I've done everything as I should. So you can use the ABCD when you document as well, and just put in all your findings and what your actions were at that stage. And at the end, make sure you sign who you are, what's your name, You don't really see that, to be honest with you, that often, but it's encouraged to make you put down your GMC number. Anyway, people can find it very easily, even on Google. And how do they get in touch with you? That's actually very important. If something's gone wrong with this patient again, or the nurse is not very clear about your documentation, or other specialists wants to have a chat with you about what's happened, then make sure your bleep number, your contact number is there and it's visible. So that's pretty much the ABCDE song done. There are so many ways to get this even fancier and better. I think it's on Oxford Medical Education I came across this. They call it the best medical mnemonic ever. So it does include, again, you start with your ABCDE. However, you can just carry on until you got to the Q. I'm sure you can make it even longer than that, but I'm not going to go through all of these. What we want to get from today's lecture is the ABCDs. Right. This is the part of the presentation where we talked about ABCDE. I think the questions will go at the end. I think we should just go through some some clinical cases. I realized I didn't actually look at the time, but it's 10:58. So first case is a 62-year-old male. You're a doctor on the ward. You're carrying 3 bleeps. It's actually quite possible in the NHS. Don't want to scare you, but it is possible. You were asked to see a gentleman who's complaining of chest pain by the nurse. You were just walking through the ward anyway. So you were asked to see a patient. I've put in some information here already, like the airway is patent when you review the patient. He looks a bit breathless. His respiratory rate seems to be on the higher side. His saturation is on the lower side. But when you feel their chest and you listen to their chest, it actually doesn't sound that concerning. Nothing really, no extra sounds that make you worried or reduce their range or anything like that. They do feel quite warm peripherally. The neck veins look fine. The blood pressure seems to be okay. They're a bit tachycardic though. Disability assessment, not much to say. When you expose the patient, you see one leg/calf looking significantly bigger than the other one. Now, just, I guess, put in the chat, people, very quickly, what do you think, given all this A2E assessment, what further actions you might do, what further tests you might ask for, and obviously it's based on what common differential diagnosis would you consider in this case. I do have the chat open here as well, so I can see when people write things down. Okay, Daphne, very good. Pulmonary embolism. You might want to do a D-dimer, a Well score. Cool. Oxygen, very good. I like that. So remember, as I say, even whatever stage of your training you are, as a clinician, if you're faced with this, you may be like, okay, this is a PE. I'm going to do this right now. But do keep in mind your A, B, C, D, E's. So you're happy with A, but you get to B and you see your patient is tachypneic and their saturation is low. Do administer that oxygen. Do sit them up. Do consider, exactly like Kay says, ABG, a chest X-ray and ECG. Analgesia, says Nikhil. Yes, very, very true. He's got chest pain. Stockings, compression. Okay. Fluids, low molecular weight heparin, and a Well score. Good. These are all very helpful bits, snippets of what I would consider correct information. So I put in like that. But yes, so based on the ABCDs, you found them breathless, sit them upright if they can, give some oxygen, their SATs are low. There didn't seem to be any abnormal breath sounds, but do that ABG. And again, you consider the chest X-ray then as well. C, they're tachycardic and they have chest pain. Make sure you do get that venous accent and the blood test sent for, as you mentioned, D-dimer, cardiac markers like troponin, NT-proBNP. If you're worried about this patient, call your senior. That's the best time. You've done your A2E assessment, you found these. You may be worried for whatever reason they don't look right. Their pain is extreme. Their saturation is not picking up. So the saturation is not improving. Do call your senior. So common differential diagnosis for somebody presenting with chest pain, not necessarily this case, but it would be pulmonary embolism that was mentioned, acute coronary syndrome, pneumonia, pneumothorax, pleural effusion, pericarditis, reflux, and even peptic ulcer disease. It is very common. I've put them on in this picture. It's a very helpful image from Picturing Medicine. Think about your life-threatening causes. Some of them were mentioned, like the PE, tension pneumothorax, a dissection, ACS, esophageal rupture. And there's some other ones which are not necessarily life-threatening, but they could be down the line if they're not addressed anyway. So all the other respiratory and non-respiratory causes of chest pain. The pattern of assessing will start, as always, with an ABCDE. You would have done an ECG, see if it fits with a STEMI. You do the due diligence of contacting the PCI lab if that is needed. If this doesn't look like a STEMI, you again, as part of your ABCDEs, you've asked for some more things, more tests, and then you get to your diagnosis. Again, it's there's a lot to go through, and I don't think it's really important to go through each one of them because I'm pretty sure guys, through your training what are the bases or what needs to be done with each of these, whether that's a tension pneumothorax, a tamponade, a dissection, PE. Just quick one. What do you think is going on in this ECG? Let me see some answers. Not seeing any yet. Oh, Francis. Is it STEMI with a query mark? Absolutely. Why not? Any other? Devney, ST elevation from K, lead 1, depression in 3. You're right, there's an ST elevation here, and there's some in AVL as well, you might notice, and there's some ST depression, lead 3, AVF. X-ray here on the left, top left. I appreciate this is not a great way to assess a chest X-ray. This is a Google picture onto a PowerPoint presentation. If you can spot it, see what you think. Again, I'm going to look in the chat and see what people think about this chest X-ray. Again, top left. Pneumothorax. Cool. Let's move to number 2. So it's top right, I would say. I'm not seeing any responses, so maybe a bit tricky. That's right. Let's go to bottom left. Well, actually, this X-ray is we've seen it before. Okay. Last one, bottom right. Yep. Okay. Right. Thank you, Kay. Very active. So yeah, that's a tension pneumothorax here. As I appreciate the chest X-ray. It's not a great thing on PowerPoint presentation, but you see a tracheal deviation away from what looks like a very just not nice looking left lungs, and that is a pneumothorax indeed. Here, that may be an aortic dissection. Here is a pneumonia, and here is a large left-sided effusion. These are things that can give your patient chest pain. Remember to always escalate to your senior if you come across these concerning diagnoses and involve other people, other specialties. Case number 2 is a patient who feels breathless. She's an 82-year-old female. Again, you go through A to E's, your A is patent, but again, she looks breathless. Respirators up, SATs are low. You hear widespread crackles when you listen to her lungs. She's quite cold peripherally. The JVP seems to be elevated. She's hypertensive, she's tachycardic, and you've noticed she's got pedal edema and sacral edema as well. Where's the chat? for DVT patients, sorry, I'll come back to your question later, Kate. So similarly, let me see some questions or some answers here about, given your ABCD assessment, what would be your actions and the differential diagnoses? So focus on your actions as part of your ABCD assessment. Good. Administer oxygen, do your ABG, do a chest X-ray. Okay, very good. So in a very similar pattern, you sit your patient up if they can, give that oxygen, start high, then titrate down, gear your ABG, see what's happening with their metabolic / respiratory status. Get some bloods done if they don't have a cannula, or if they do. Cardiac markers, D-dimer again, a full blood count, Usenes, venous access. Thank you, Salma. ECG and chest X-ray, speak to your senior. If you're worried about the patient appears to be, this lady looks quite unwell, I must say, given the combination of things that are happening there. So things you have to consider when seeing a breathless patient is commonly asthma, COPD, pulmonary edema, pneumothorax, pneumonia, PE, MIs, and arrhythmias, effusion, and anaphylaxis. I must say anaphylaxis is very rare these days, but still happens. So again, very helpful picture from Picturing Medicine, all your causes, or the most prominent causes of shortness of breath. They can be central, they can be respiratory, non-respiratory, cardiovascular, and so on, neurological as well. We've gone through how do we assess the patient. So indeed, the patient in case 2, this is her chest X-ray. She's got quite a fuzzy hilum, looks quite full, not very easily demarcated. Bases are not really seen and quite fluffy. You'll see, and probably predating some pleural effusions as well. So her diagnosis is indeed pulmonary edema. Case number 3, this is a young female, 22, and your nurse asked to see her because she doesn't seem to respond. She's unresponsive. So she's snoring when you see her. Her respiratory rate seems to be low. Her SATs are low, but she doesn't seem to have any odd sounds when you listen to the chest. Here, a bit hypotensive, a bit tachycardic. Glucose I've included here, it's normal. Her GCS is low though. But she doesn't have any signs of injury or hemorrhage. You do notice, though, some needle tracks and skin cuts. Again, guys, okay, intubate, the GCS is 8. Okay, let me see more responses. Remember, we've gone through A, B, C by the time we've got to the D. Okay, I like that. Call senior, first one. Yep. Anesthetist, lovely. Good. Monitor, good, good, good. Very good. So I agree with the fact that you do need a senior for this patient straight away, or maybe anesthetics. You found a little bit of a problem with your airway, so you will try to manage it yourself first. You will look if they have anything in their mouth. Snoring doesn't usually indicate that they have something in their mouth. It just predates the fact that they're sleepy, drowsy, obtunded. See if you can manage their airway with a head tilt, chin lift, or a nasopharyngeal or pharyngeal. You would give some oxygen because you've picked up that the oxygen is low. The one thing that I've included here as well you have to consider is bag mask ventilation. So actually this respiratory rate is quite low. So efficient ventilation or oxygenation doesn't really happen with a respiratory rate of 6. So you need to actually apply the bag mask and ventilate the patient yourself. Again, you would have probably called your senior in the meantime, or first step, sorry. Maybe they help you, or the anesthetist helps you with that. You would do an ABG, their SATs are low. You do some bloods as well. Think about in a drowsy, comatose patient, think about taking lots of blood tests for different things. Make sure you check the glucose, the calcium as well. Blood cultures, paracetamol PNS stands for paracetamol salicylate levels. So we've seen that this patient has got needle tracks and skin marks. They probably have a history of deliberate self-harm or drug overdose. Monitoring, I like someone mentioned, think about, do I need a defibrillator for this patient? They're a bit hypotensive, a bit tachy, respiratory rate. There's just so many things going on, and you will never be told off if you attach monitoring to your patient and defibrillator if they appear to be very unwell. Check the glucose drug chart. Think about drug antidotes. So maybe you've had some history from your nurse that this patient takes a lot of opioids, or they're admitted with an opioid overdose or benzos overdose. So you think about antidotes. Think about CT head if everything looks fine, but they're still drowsy. So common differential diagnosis for an unresponsive patient, there's so many things to consider. Sometimes the D here just takes a lot of time. Make sure you do your ABCs first. So they can be hypoxic, hypercapnic, they can be hypotensive, like we see in sepsis patients. There's many metabolic abnormalities that can make the patient unresponsive or drowsy, like low BM, a very low sodium, maybe a very high sodium as well, like we see in patients who are incredibly dehydrated or in HHS. Calcium, potassium, renal failure, liver failure, just they're not able to excrete all of those toxins, so they can be uremic, or they can be having hepatic encephalopathy. Thyroid, it's hypothyroidism. You see the myxedema coma. You can see, and I have seen that in practice as well. Drugs, so common ones, opioids, alcohol, TCAs, and benzos. If the patient has had seizures and they're now post-ictal, they can be similarly unresponsive. If there is a CNS infection or a mass or a stroke, especially if it involves the deeper structures of the brain, like the midbrain and the pons. So think about an unresponsive patient as definitely a medical emergency. So I like that someone included call senior / anesthetist straight away. Do involve people early with an unresponsive patient who's also having to have problems with the A, the B, and the C as well. Try to do whatever you can do, like the airway adjuncts, give them oxygen, give them some fluids. In the meantime, make sure that you ask your nurses or your other colleagues to bring up some notes, whatever we know about this patient that may be a helpful clue about what might be going on. And as part of your D and E, you do perform at least a brief neuro exam so you can get an idea about their tone and whatnot. Anyway, case 4. So well done, guys, for that one. Case 4 is a 40-year-old. He was brought into hospital because he had some seizure. However, the seizures have now stopped. So the patient came with an ambulance. They've helpfully put in a nasal pharyngeal airway in situ for your A. B, he's tachypneic, hypoxemic. His chest sounds pretty good. He's very hot to touch. His JVP is not raised. He's hypotensive and tachycardic. His glucose is okay. His GCS of 3. He's got really raging temperature. You also notice all of this rash going on in his body, and he seems to have some neck stiffness. So, okay, thank you. So similarly, what are your actions based on your A, B, C, D, E's? Let me see some responses, please. Time the seizure if happens again, call help, sit patient up. Says K. Sarah says sepsis 6. Okay, get access. Right, so yeah, very important things need to be intubate. Okay, this GCS is very low indeed. So again, call your senior straight away. This is an unresponsive patient with lots of things going on in their A, their B, their C. Manage the airway as you can, but somebody's already put a nasopharyngeal, make sure that that's enough. For some people, it's not. It will not really make their airway patent, so they need an oropharyngeal, or you need an anesthetist to think about something more advanced. Give the oxygen is low. Get the access so that you can take the bloods that you need, including blood cultures. You'll give the fluids as well. The patient is hypotensive. You would have done the ABG before that, chest X-ray and ECG. So somebody mentioned sepsis 6, very true. There's a combination of things here that may predate a diagnosis of sepsis. There's a temperature, there's an unusual rash, there's a hypotensive tachycardic patient. So proper surge response with a possible infection. So think about your antibiotics, in this case, antivirals as well, antipyretics, how to cool down the patient. And I put down there with the red sepsis 6. So sepsis 6 started off in, I think, 2000, at least in the UK in 2011. They looked at the surviving sepsis campaign from the States, and they saw that following certain things, when you assess a patient with suspected sepsis, if you do those 6 things, it's almost a 50% increase in their, decrease in their mortality and morbidity, length of stay, or ITU stay. 50%, that is a lot in medicine. That is a lot of patients saved. So the sepsis 6 includes you to give the oxygen, so the SATs are 94 and above. You take the blood cultures, you've given antibiotics, you've given fluids, you've measured your lactate, and you're measuring your urine output. So if you think about it, that's your B, that's your C, that's your somewhere, maybe C, maybe later down, C. That's also part of your ABG, so A, B, and C as well. And urine output is part of your C. So you would have covered a sepsis 6 within your first ABC assessment. It's a busy slide, but remember sepsis. So with the sepsis 6, it was interesting. There's a lot of people have just, it was so much in the media that people came to hospital saying, I'm not sure, I may have sepsis, because they read a lot of information about it. But that's a good thing. It makes people aware of getting checked when they're not right. Anyway, so it's a life-threatening organ dysfunction due to a dysregulated immune response to infection. It doesn't necessarily mean that a patient has to be hypotensive all the time. Sepsis doesn't just mean hypotension with an infection, but it's a high morbidity, high mortality diagnosis. So getting it right from the start is very important, and your ABCDE will help you a lot in that. Quick one, case 4 is a patient who actually has seizures. So they have seizure, their airway seems to be patent, but sometimes they grunt, they snore. There's these phases when they're breathing really fast, and then there are times that they're not breathing at all. However, on a general, it seems to be like the SATs are okay. Auscultation doesn't seem that remarkable. They feel a bit cold, a bit tachycardic. They're GCS of 3, and they don't have the signs of injury, hemorrhage, or rash like the previous patient had. Again, what I want you to consider is to call for your senior help early. Kay mentioned time the seizure if it happens again. Absolutely. So if you were asked to see someone who has a seizure, asked about the timing. You'll notice that there are very important brackets and what things we can do based on how long the patient has been seizing for. And generally speaking, a seizure has not stopped. Even if it stopped briefly and then reoccurred, we only say that a seizure stopped when they've been at least 30 minutes not seizing, when the patient is not seizing, at least 30 minutes. So if you can secure the airway, fine. If you cannot, do not force the teeth apart. So think about just a nasopharyngeal if you can insert it. Put the patient in a recovery position, like here in the picture. Get some oxygen on board. Get some bloods, some access, so you can give medications or take bloods, ABG, VBG if you can't really go for the artery. Time the seizure. Get ready for some antiepileptics. Frequently it's benzos, lorazepam, diazepam. They can be given IM as well if you're struggling. Diazepam can be given rectally as well. Midazolam can be given buccally. So think about Pabrinex, especially for malnourished or alcoholic patients having seizures. And think about antidotes like flumazenil in somebody who may have had a benzo overdose and ECG. Common causes of seizures, again, they're quite complex. They can just have epilepsy in their known patient or an unknown first presentation. It could be a drug overdose. It could be metabolic causes for seizure as well, hypoxic, hypercapnic in that as well, or an infection / mass / trauma. So we mentioned the timings. If we get to about 5 minutes and the patient is still seizing, then we give the first agents, which is usually lorazepam or diazepam or midazolam. If again the seizure continues or they've not been seizure-free for 30 minutes, it's still going on, and think about Keppra, phenytoin, I'll leave that slide there. It's very busy. So sorry if I've overrun a little bit. Friendly tips from my side on how to be a good, this is an area here. It shouldn't be how to be a good but safe doctor. It should be how to be a good and safe doctor in the NHS. My apologies. So when you look after a patient, remember it is a team, but you are a very important part of it, and you are never alone, especially when you assess an unwell patient. Do raise your concerns as soon as you can. Do get your colleagues involved, whether that's your senior or people of your grade or nursing staff. Get them to do something for you, something to help you with. Get notes, get drop charts, put the monitoring on, and so on. Be open when you communicate with your colleagues or patients or relatives. Be honest. Talk about escalation with your seniors and patients. When in doubt, ask. Definitely read and stay up to date. It's so important. People can get complacent and they reach a level of confidence and just not evolve from there. I find up to date incredibly useful. I appreciate that it's expensive. Luckily, my trust gives it for free to people who work there. DQ Medics, amazing resource. Foundation program, I still look at it sometimes. BMJ best practice. I think that's all. Sorry to overrun. Thanks for everyone's attention. Quick mention, intubate. So yes, it's definitely consider it when the GCS is 8 or lower. So what the guidelines would suggest is to consider intubation. So don't just rush for it, especially if you're not the person who's doing it, but definitely consider, absolutely, top priority. Okay, I'm not sure what happens now. Are we getting questions?
Yes, thank you so much.
Thank you for everyone's attention and contribution.
Thank you. It was very, very informative. I know I learned a lot, took a good amount of notes. So thank you so much.